Can you hear me? Yes. All right, we're going to get started here. We are group number 34. I am student Dr. Chris Myers, and I'll be followed by student doctors Akta Patel, Catherine Brooks, Jaffe Liu, and Josh Arden. And this is case 4. Is it loud? No. This is case 4, the case of I have bilateral weakness in my lower extremities. This was the chief complaint from our patient. He's a medical professional or possibly a fan of medical dramas. So here is the SOAP note that we got. This was actually written by one of our medical students, so it's a little sparse, missing some information. We'll take a look at the subjective portion here. The patient is a 32-year-old male presenting with a complaint of weakness of his bilateral lower extremities. He first noticed numbness and tingling in his hands and feet, and then noticed he had weakness of his bilateral lower extremities. The weakness does not change with the time of day and does not get better with rest. He noticed that his weakness is more progressive as the day goes on. He first noticed the weakness in his lower legs, but now it's progressing up to his thigh muscles. No recent illness other than a mild cold 2 weeks ago. And for social history, he's an avid bicyclist, but he hasn't been able to ride for 3 days. I've highlighted kind of the important things. All these are important for the diagnosis. And I think it's also important to stay mindful of the fact that he's an avid bicyclist, but he hasn't done it for 3 days, so it's probably a testament to the severity of his weakness. So now we're going to take a look at the physical portion. So the patient was afebrile, normal vitals. On physical exam, he was well-developed, well-nourished male and no acute distress. CV, respiratory, and abdominal examination were non-remarkable. However, on neuro exam, his upper extremities were 5 out of 5, strength-wise. His lower extremity strength was 3 out of 5, so that's obviously significant. Biceps and bilateral tricep deep tendon reflexes are plus 2 out of 4, so normal. And the patellar and bilateral Achilles deep tendon reflexes are absent. His gait is abnormal in appearance in the movement of his legs, and he has to flex at the hips in order to lift his legs to walk, so something like this. Other than that, I'm going to turn the mic over to student Dr. Akta Patel, and she's going to talk about the working and differential diagnosis.
The mic on to student Dr. Myers for the diagnostic workup.
Thank you, student Dr. Liu. So now we're going to talk about the diagnostic workup for GBS. So GBS is very much, or the diagnosis of it is very much a diagnosis of exclusion. We pretty much have to rule out all those other things in the differential diagnosis before we can definitively say that somebody has GBS. So, and definitely the main part of the diagnosis, just like Dr. Karula and other professors have told us, that most of it's going to come from the history and physical. The labs are just going to give us some additional information. So some of the clinical features, like a student Dr. Liu said, males are a little more represented than females. This often follows a recent infectious process, recent vaccination, or possibly even after like a surgery. The clinical course is important for this disease. So GBS will progress over a period of days to 4 weeks. It'll plateau for 2 to 4 weeks, and then it will recover over a month to 2 year period. So if it had a more insidious progression, then we might call it chronic inflammatory demyelinating polyradicular neuropathy or subacute. So some of the clinical signs, and we saw this in our patient, the symmetrical weakness that is ascending, just like in this amazing graphic, along with a mild loss of sensation. Also for the demyelinating disease or version, you wouldn't expect any change in pain or temperature sensation because those are already unmyelinated nerve fibers to begin with. So also the patient can have a lack of reflexes, areflexia, and this actually occurs before the weakness itself, and that can be a pretty key clinical sign. Also, there will be sometimes autonomic features as well, such as tachycardia, blood pressure, lability, which just means borderline hypotension. And also, as this progresses high enough, it can get into the cervical region and start affecting the phrenic nerve, and then you have some major respiratory problems. And the patients are typically afebrile. So these are some of the standard routine tests. These wouldn't be performed for everybody that came in that you might suspect GBS. These would just be performed to rule out certain aspects of the differential diagnosis. So you do the CBC to rule out like porphyritic diseases, sedimentation rate to look for infectious processes that went undetected, chemistry profile maybe to look for the toxins like the botulinum toxin, heavy metals, or something with the metabolic process. Fasting blood sugar can help to rule out diabetic neuropathies. Thyroid studies, because hypothyroid myopathy presents very similar to GBS. Antibody studies, I think, was pretty well covered by student Dr. Brooks. And for vitamin B12, I think we remember from MCBM the second reaction that we learned for B12 is the isomerization of methylmalonyl coenzyme A, which is required for the production of myelin. So the main study that we would do, or that we did do, is a lumbar puncture. So we're going to do a lumbar puncture and analyze the CSF for protein content in cells. So you would expect an elevated protein content due to the myelin basic protein from the breakdown of the myelin, and no accompanying pleocytosis. The only problem with this is that you generally don't get an elevated protein content in the CSF until 2 weeks after the onset of the illness. So hopefully you're already treating the patient by then, without this lab result. And if you guys remember from blood and lymph, Dr. Pomerantz said that we'll use the top needle here, the atraumatic needle. So the second very important study is your electromyographs and nerve conduction studies. And these are just used to basically objectively be able to measure the symmetry of the weakness and also to differentiate between demyelinating and the loss of axons. And also these studies will be done serially. You'll do them, depending on the progression of the patient, but you'll do them every 6 hours or so, and you can basically graph, just like that graph I showed you, where it's getting progressively worse and then it'll eventually plateau. So you can use these studies to see where the patient's at in the progression of their disease. And then finally, you're going to do these supportive tests. And they're not supportive in the sense that they support the diagnosis, but these are just supportive in that they'll help us decide what kind of care to give the patient. So the maximum expiratory flow and inspiratory flow, those are actually pressures. You're measuring the pressure that the patient's able to inhale and exhale at. Apparently physicians aren't physicists. And then the forced vital capacity is just the basically the useful volume in the lungs. So the patient will take a deep breath in and then exhale into a machine all the way, and then you'll just measure the volume. And these are all done via spirometry. And here is a machine, a spirometry machine. And you can see right here where the patient can put their mouth on the machine and go through a period of inhales and exhales, and we can get some measurements from that. And here's just a smaller version. This is actually a USB version. You can plug right into a computer. And the reason why we do these is because of the 20, 30, 40 rule, which determines when we will admit the patient to the ICU. So if their forced vital capacity is less than 20 cc's per kilogram, we'll admit them. And this is also obviously based on their body weight. Or if their inspiratory flow or expiratory flow are below 30 or 40, respectively, centimeters of water, then we'll admit them to the ICU. And I think this segues nicely into student Dr. Liu's treatments.